Good day, everyone, and welcome to today's webinar. The Cencora Intrinsic Specialty Solutions team will be reviewing the 2026 MIPS proposed rule. Please note the session is being recorded. The webinar recording and handouts will be distributed after the webinar to the email with which you registered. Please help me welcome our first speaker, Jackie Rogers, who is the founder and director of our MIPS Consulting Services. Jackie, please go ahead.
Thank you, Julie, and good afternoon, everybody. Hope you're having a great summer. We appreciate you joining us this afternoon on a hot August day to review the 2026 proposed rule that recently came out. So we hope to give you some good insight and updates on what to expect coming up in the new year, which is really hard to say. I know everybody's getting a lot of their kiddos back to school, and so it's a busy time of year, and we just thank you for your time today and joining us. And of course, we will follow up with another webinar on the final rule when that becomes available, which will probably be, we're anticipating that webinar will be right about the beginning of December sometime. So look for more information and update to follow regarding that when that becomes finalized. But without further ado, we have a lot to cover today, and I'm very excited that we've got some great content to share with you today. Of course, we want to share that this is for educational and informational purposes only, and we encourage you to do your own due diligence on these rules and guidelines, but we do like to make sure that we put our disclaimer in here for you. There is a link here at the bottom of the page that will go directly to the proposal for you to check out all that great information on your own. As Julie mentioned, this is being recorded and the handouts will be distributed at the end to the registration email that you sent in to register for today's webinar. Additionally, I'd like to draw your attention to any questions that you have in the bottom for you to be able to put those in, and we can answer those on the fly today during our webinar if we have time, and making sure, but we certainly want to address any questions that you have, and so feel free to put those in, and if we can't get to them today, we'll follow up and do an answer via email for you, but certainly wanted to make you aware of that. Our agenda today, Jacinda will be following me, talking about the promoting interoperability category, of course, worth 25 points in your composite score. And then Wendy will be sharing with us on the improvement activities and update on electronic case reporting. And then Valerie will be sharing on the MVPs, definitions, and then also that 2024 feedback report, which it has not come out yet, and we are anticipating that, but she'll talk more about that. And then Sherry is going to go over our new and retiring quality measures. As well, Michelle will follow up on the cost updates and qualifying APM participants, and I'll have a few closing remarks to share with you on some important dates. But we do have a full house on our webinar today with presenters, and I'm excited that our senior consultants are all going to take part today in sharing on the proposed rule. But we also want to give a shout out for our project coordinating team. They are exceptional and really help us as a team stay organized and communicate and making sure that we're just getting everything together, and they really help us a lot. So I want to draw just attention and like I said, a shout out for Lee Cameron and Ramona Miner and Kelly Fussell, who are also part of our QREG team, or our quality reporting engagement group, we like to say. So without further ado, I will turn it over to Jacinda to talk about the promoting interoperability updates. Jacinda?
Thank you, Jackie. Hello, everyone. As Jackie mentioned, I'm going to be covering the promoting interoperability improvements proposed policies. So there are not any structural changes that are really happening to the promoting interoperability category. And as Jackie mentioned, it still is worth 25 points going into the 2026 performance period, but there are a couple measure modifications and a new inventory item that we're going to look at. So this first slide talks about the security risk assessment, which is an annual assessment that every practice or provider should complete each year. And they're proposing to add an additional attestation component. So when reporting this measure, currently you are attesting that the assessment was completed. But in addition, what CMS is now proposing is that you're also going to attest to conducting management activities. So these management activities are in accordance with the HIPAA security rule, and that HIPAA security rule really is about helping you identify threats to confidentiality and just making sure that your electronic patient health information is secure and not compromised, and you're really looking to identify really anything that can improve. And so what CMS wants you to start documenting and what you're going to be attesting to is the fact that you've done that additional management activity. So you're really looking to really prioritize the items that could be at risk and write out those mitigating steps that you're taking to improve your EPHI security. So the next measure modification that CMS is proposing is the SAFER Guide. And this is a modification that the SAFER Guide will still be required, but the version is changing. So currently on the healthit.gov website, and you'll see the link right there, there is a 2016 SAFER Guide. And this has been the guide that has been available for several years. And so what CMS has done is they've updated that. And so the 2025 SAFER Guide is now available. You can actually go to that website, look at that guide. It's been updated, and so it now includes some more items such as AI and how that could be impacting your practice, and just a number of recommendations that as you go through that SAFER Guide, there's things that you could be looking at putting in place, and this guide is going to be that self-assessment that's going to help you to kind of know what items you can put in place. Now, the 2025 guide is not going to be required for 2025, so when you report, as long as you've completed the self-assessment on the 2016 form, you will meet the MIPS measure requirements. But this is something going forward that CMS is proposing to put in place. And then the third item that is impacting the PI category is they're adding additional inventory item under the public health and clinical data exchange objective. And this is going to allow those who are participating with a TECFA, which is the Trusted Exchange Framework and Common Agreement. If you have one of those in place and you report to a public health agency, you then can also earn a bonus, and that's what the new inventory item is going to be. So currently there's still participation under a different objective within the PI category, and that's the Health Information Exchange objective. And that is for participating with TECFA, but this is in addition. So this is something additional that if you put in the steps to report to the public health agency and get that confirmation, that will be bonus points that will be available to you. Now, there are also some RFIs, so requests for information, that CMS is looking for your feedback on. And the first one is how they are reporting the PDMP measure. And so currently it's an attestation-based measure, but what they're looking to possibly do is change it to a performance-based measure, possibly modify the types of drugs that are included. So this is something that if they're really looking to increase the effectiveness of the PDMP use. And so if you have feedback to provide, you can definitely still provide that. And we're within the 60-day window up until September 12th of 2025. I encourage you to submit your feedback, and there's definitely details here as to how to go about that. Another RFI that is requesting your feedback is the Public Health Agency reporting, and if there's alternative ways to report that information, that's one of the things that they're looking for new concepts on. And so if you have different ways that you report to public health agencies, definitely give that feedback, give that idea, because there might be ways that CMS could capture that data, and you may be able to benefit from sharing that information with CMS. And then the final RFI is really not only for the promoting interoperability category, but in general, the use of the FHIR technology. And so CMS is requesting information as to really advancing the digital quality measure reporting and utilizing that FHIR technology and how your organization or practice may be utilizing that. So that's another opportunity to provide your feedback. And so the file code for any of these RFIs is CMS-1832P. So include that in your submission, and just give any details that, if you're supporting or how you're utilizing or your background. That's really what CMS is encouraging everyone to do by that September 12th deadline. And then with that, I will turn it over to my colleague, Wendy Renfro, to cover improvement activities.
Perfect. Thank you, Jacinda, and good afternoon or maybe morning to everyone. So glad you joined us today. So for improvement activities, honestly, there's not a whole lot this year. There were very few updates, but what they did do is they're trying to focus on streamlining the inventory so that you will, first of all, you'll notice some changes to the subcategories here. They've removed achieving health equity, and they have added advancing health and wellness in its place. They're adding 3 new improvement categories, which you see here, modifying 7, and then removing 8 improvement categories. So kind of what I'd like to say with this is the inventory, again, it updates every year. So I would encourage you to make sure that you review that inventory when it is finalized. And something we do for our clients is we actually narrow this process down by just a few. We get some feedback from our clients, just so it's not so overwhelming. But you also need to make sure that you have all the data validation requirements and that you have that really prior to submitting your information when you go to submit for your QPP at the beginning of the following year. So just something to remember there. Also for MVPs, they have little subsets of improvement activities. So you'll want to be sure that you're checking out that very small subset. It's like 10 or 12 usually for most of the MVPs. So you'll want to look there to make sure that you're participating in one of those. And if you're not, that you need to change your participation. The last 90-day period for improvement activities for 2025 starts on October 3rd. So just a few things to mention there, not a whole lot for improvement activities. Next, we'll go to the suppression of electronic case reporting. And first of all, what they're doing is they're actually proposing a policy. There's no policy in place right now for PI. There is one and has been one for the quality category, but they realized they needed one this year, and so that's where we get this proposal. There was a temporary pause that CDC had. They couldn't onboard new healthcare organizations, so they took this pause. And so with that, CMS decided, okay, we need to do something because we have a lot of clinicians who do need to report on this. And what this policy would mean that you are not scored for this particular measure, and it'll actually take effect this year in 2025, even though it's in the 25 proposal for 26. So I want to be sure to be clear on that. Now, this measure is still required to be reported, so you're going to need to report a yes, no, or exclusion, but you're not going to be negatively scored. So make sure that you are still reporting this. And the reason they do this is, again, because they needed some flexibility. This is a circumstance that really was outside of the control of MIPS clinicians this year. And so, again, they're deciding to propose the policy, and then after that, they were actually going to apply that to the electronic case reporting. So that's it in a nutshell. I will now pass it on to Valerie to discuss the MVP update.
Okay, thanks, Wendy. All right, so there are some changes and updates for MVPs this year. The main thing is that they proposed 6 new MVPs, which is going to bring that total inventory of MVPs available up to 27. Couple radiology, neuropsychology, pathology, podiatry, and vascular surgery are the new ones. So since the program is sort of moving towards MVPs, every year they're going to be adding MVPs. So if you don't have one this year to report, you probably will in the next couple of years. So keep that in mind. And if you're interested in any of these MVPs and the measures that would be reported, you can see the proposed guide, and there's a link there that'll be in the information that you get. And then, of course, with all the measure changes to the improvement activities and to the quality category, when they retire and add measures, they have to make adjustments to all the MVPs. So there's actually adjustments to every single MVP this year due to those measure changes. So like Wendy said, you want to make sure that you are looking at those MVPs and those measure selections at the beginning of every year and make sure you're reporting something that's still valid. A couple other policy changes proposed for MVPs. So currently, CMS uses Part B claims to determine if you are a multi-specialty group. And they are proposing to allow groups to attest to their specialty composition during that registration process. So right now, if you are a multi-specialty group, which is 2 or more specialty types in the same tax ID. Currently, if you're reporting an MVP, you have to report it to subgroups. So those different specialty types could report the same MVP or different MVPs, but you have to report as a subgroup. So they're proposing first to let you determine your own specialty composition rather than using claims to do that. And then a follow-up to that is that if you are a single specialty group, then they are going to allow you, if you're small, if you're a small multi-specialty group, you can still report as a single group rather than as a subgroup. So like I said, previously you had to report as a subgroup if you had multi-specialties, but they are proposing an exception to that policy. So you don't have to do that if you're a small group or a single practitioner, obviously. And then the final updates are just related to registries. So qualified registries and QCDRs have to report or support a new MVP if it's relevant to the clinicians that they support. And normally that starts then just the next year. And so they are giving those entities an extra year basically to support that MVP. So now they will not be required to support that MVP until the next performance year. So if these MVPs are finalized, then registries and QCDRs would not have to support those until 2027. So keep that in mind when choosing MVPs. You want to make sure that if you're going to report that MVP, that you have an entity that can support that MVP for you. There are some RFIs related to MVPs for future years where they're just looking for some information. We wanted to give you the information if you had any comments to make on that. One of them is regarding core elements in an MVP. So they're specifically looking at the quality category and looking at saying, these specific quality measures would be required to be reported if you choose this MVP, and then you could probably also choose additional measures to report. Let me go forward to the next page, please. And then they're looking at procedural codes for MVP assignment, like looking at potentially assigning MVPs to providers in the future. So if you have any information that you would like to share about that, the information to make comments is listed there. And then Sherry's going to cover the quality measure changes, but we wanted to give you some information about the measures in general and some definitions. So there are 4 specific measure types that are, I would say, the most common measure types. And we wanted to kind of go through those for you so you understood the differences in the quality measures. So there's ECQMs, MIPS CQMs, QCDR measures, and Part B claims measures. I would say these are the 4 main measure types. ECQMs are electronic, so they're going to be captured through your certified EHR. The data is very structured. It's got to go in a specific field tied to a specific code. And the data for these measures is going to be collected on all of your patients, not just Medicare patients. So every patient, regardless of payer, should have the data collected for ECQMs. And some measures have multiple types. So you might have one measure, like a documentation of current meds, that's going to have an ECQM version, a MIPS CQM version, a Part B claims version. So when you're reporting and choosing measures, make sure that you're looking at the measure specifications for the right version of measure that you're going to report. And then ECQMs typically, if there's multiple versions, the ECQM version is usually going to have better benchmarks for scoring. That's not always the case, but most of the time it is. So if you have the option to report an ECQM versus a MIPS CQM, you probably get better benchmarks and better scoring from that ECQM. A MIPS CQM is going to be a little bit more flexible in where the data can be collected. So it's not required to be in your EHR. You can collect it from paper. You can do it through a registry or in your chart. There's not that structured component that's required, so you can use keywords and things like that. It's a lot more flexible. Again, data is collected on all patients, regardless of payer, for this measure type as well. And then QCDR measures, so a Qualified Clinical Data Registry. This is a CMS-approved entity, and they have the ability and the flexibility to develop their own measures. So a lot of times those are going to be really specific to the customers that they support. So, for example, the Aqua Registry with the AUA or the IRIS Registry for ophthalmology, they are QCDRs, and they can develop their own measures that are relevant to their scope of their customers. So those measures can usually only be reported through that specific QCDR. Occasionally, other QCDRs can borrow a measure from another registry. But again, data is collected on all patients that qualify for the measure, regardless of payer. And these are usually going to be more specialized and specifically focused on a specialty type or a problem that they're tracking. And then the final is Medicare Part B claims measures. So this is like the measures that have been around the longest. There's very few of them that are left. And these are the only measures that are reported on only your Medicare patients. It's reported on claims. You use codes for reporting with a claim to CMS. And this measure type is only available for small practices or single clinicians. So they're harder to track and monitor throughout the year. If you're going to choose this, you're going to have to be really on top of keeping track of making sure that you're getting those codes reported, and you won't really have a way to see how you're performing on that data until CMS provides that feedback, the following year. There are a couple of other measure types that I just wanted to highlight for you. So there's CAPS for MIPS surveys. These are going to be like patient surveys. You have to register in advance to participate in this, and it counts as one quality measure. And there are some CAPS surveys in some of the MVPs, so you'd have to look at that if that's something that you're interested in. You have to register for your CAPS survey before you register for your MVP. There's also a measure type called Medicare CQMs, and this is only available for Medicare Shared Savings Program ACOs, and it's specific to them. You can't choose to report those unless that's what your ACO is reporting. And then the final type is administrative claims. So these are automatically assessed on your claims data. They are also only on Medicare patients, but you don't report them. So they're going to assess you if you meet those measure requirements. There are 4 claims measures right now. And most of the time, those are assessed on larger practices that meet that measure volume criterion. And then just as a review, submission for quality measures is done through claims right, through the Part B claims measures. You can sign in and upload. That's done through the QPP website, and that's where you're going to get a file, like from your EHR, and you'll upload that file to QPP, and it will be calculated and scored for you. Or a direct API, and this is going to be done through like an EHR registry. So when you submit data through your registry and you click submit to the registry has a connection with QPP, and they submit that data through this direct API. Those are the 3 ways you can submit data. And then finally, I just wanted to cover the 2024 feedback. Like Jackie had mentioned, the feedback is delayed this year. Normally it comes out in July, August timeframe. They've delayed it once, and it looks like they've delayed it again. So this is a screenshot of what it looks like when you log into QPP. And they have a little timeline across the top, and we noticed that that timeline has been extended. So the feedback will come out starting in September, where they'll tell you how you scored on things, but you won't learn how that translates to your payment adjustment that will start in 2026. That payment adjustment will not be out until October. And then the targeted review time period opens in September as well. So if you have any issues on your feedback, you'll be able to open a targeted review for CMS to review that. And the screenshot here shows you just where you need to look for your performance feedback when it's available. And so with that, I think I will turn it over to Sherry to cover the quality measures.
Great, thank you, Valerie. It's a great lead-in. So for this year, Medicare's ultimate goal is to streamline the process of submitting measures, descriptions, to make it easier for providers and less cumbersome in evaluating what their practice needs to submit and do. For 2026, we have 5 new measures that have been proposed, which includes 2 ECQMs. They proposed to remove 10 quality measures, and then some substantive changes to at least 32 quality measures for 2026. Okay, so for the new measures, which are listed here, these are, like I said, MIPS CQMs and ECQMs, and patient-reported falls in plan of care, patient standardized kidney transplant waitlist ratio, hepatitis D virus, and then screening for abnormal glucose metabolism in patients at risk of developing diabetes, and then the diagnostic delay of venous thrombolism in primary care. Then for removal of measures, there's 10 measures that they're proposing to remove, but there's 3 that may impact your overall score. And those 3 are 419, which has been around for a while, which is, the overuse of imaging with headaches. So if you're using that measure right now, just kind of be on the lookout for that in 2026. It may not be available to use for next year. The other one is the screening for social drivers of health. That one's kind of relatively new, but they are proposing to remove that once again for 2026. And then another new measure, newer measure is 508, which is the adult COVID vaccine status. So any of these measures that are part of an MVP or other type of category like that, if they are removed for 2026, they will also be removed in those type of categories as well. So when we start going through the MVPs and other things like that, just make sure that we're aware of that as well. Okay. And then, as mentioned before, there are over 30 measures that have significant changes, but most of them are pretty mild and will not impact your overall score. The top 5 that I have listed here are ones that are more notable, like advanced care plan. They want to remove the Medicare Part B collection type. Documentation of current medications. In the past, when we have an exception in this measure, we've listed it as a medical reason for not documenting this. They're changing that to adult acute health crisis as the reference code for that measure. The diabetic eye exam measure, now this one could be, you know, a substantial hit to some practices because they want to remove the MIPS CQM collection type, and they changed the ECQM collection type, mostly the description and that type of thing for that measure. Then the other significant change that could be relevant to your practice, which this one might make it easier for you to meet this measure, is previously they made it, you know, where you have to have a consultant report received in your practice once you have referred a patient out. For 2026, they're proposing to include a procedure report. Since if you referred a patient out and they had to have a certain procedure, then if you receive that report back, that is considered closing the referral loop. That could be a good thing. And then the last one is the 493, which is the adult immunization status. They have decided to add hepatitis B vaccine as a list of routine vaccinations for any patient that's over the age of 19 and older. And once again, these are like the top 5 that could affect your practice more often than some of the others. So that's pretty much the main changes. With that, I'll turn things over to Michelle. Thank you.
Thanks, Sherry. I will go through cost updates, which for the 2026 proposed rule really isn't much, but I'll touch on what they have changed. As far as their inventory goes, they're not really proposing to expand or reduce the existing inventory for 2026, so we'll still see the list of the 35 cost measures that were there in 2025. They are proposing that starting in 2026, if they were to have new cost measures come on board, that practices would get a 2-year informational only feedback period before those new cost measures start to impact their scores, which I think is going to be really helpful because then you won't get kind of sidelined by a new cost measure. You don't know how it's going to report or track and how it's going to impact your score. As we all know, cost is one of those categories that we kind of see as a black hole of information. We don't really have a lot to go on during the actual performance period. We only get that information back the following year when final feedback comes through. And down there is a link to the other cost measures if you want to explore them in more detail, but I'll touch on some of the measures. Oh, just one of them had a change. So 2 of the global measures, Medicare spending per beneficiary clinician and total per capita costs. TPCC is the one that's primary care related. And so they have updated this to refine their attribution logic, which I think is going to be very helpful to specialty practices in particular, because previously, if you had a specialty taxonomy associated to you, your candidate events would not be included for attribution and you wouldn't get this measure given to you. But if there was an advanced practitioner, like a nurse practitioner or a PA, if an advanced care practitioner did not have that specialty taxonomy, then they would sometimes, if your practice was large enough, pull in patients and you would get this measure erroneously. So they're trying to refine this so that it doesn't pull in primary care related measures for a specialist group. And they have a couple of other updates as well. They are going to require the second service to be an E&M service or other primary care service within 90 days of the initial event, and then require the second service used to initiate that event to be provided by a non-specialty provider. So if you are a PA or a nurse practitioner and you're working with a lot of urologists or something like that, then they see you initiate a candidate event, they will not include that. That is the proposal. And then just for reference, here's a list of all of the other cost measures. These are episode-based measures. They are a little more refined in their attribution logic. You can read through those and get a lot more detail on that link I had provided previously. And now I will go ahead and touch on QPs.
So Michelle, I just want to interject for just a second, and we had some good questions come in. So would you summarize the advantage of doing MVP over traditional MIPS, and what would be the disadvantages of moving to a selected MVP?
Oh, sure. I can take that one. There are a couple of advantages of reporting an MVP. It's a more specialty-driven path. So you have a couple of different paths you can report MIPS through. MVPs is more specialty-related. So they have a smaller list of quality measures that you choose from. You're also going to be scored on less quality measures. So traditional path, you're scored on 6, and they take your score out of 60. And then with the MVP, you would be scored on your top 4, and you would be scored out of 40 in your denominator. So sometimes that makes it a little bit easier for practices who maybe do well on a 4 measures, 4 or 5, and then maybe they have 1 or 2 that bring their original traditional quality score down. The MVP can help in that way. Also, it typically will score you on the ones that are more relevant to your specialty. And as far as the cost category goes, with MVPs, they reduce the inventory of cost measures that are available to be attributed to your practice or your group. And so instead of maybe having some measures that don't apply at all, like maybe the diabetes measure gets pulled into a large urology practice just because they happen to have some patients that met that criteria, they wouldn't be considering your practice for that cost measure if you reported the urology-specific MVP. They would only be looking at the ones that they deem applicable to the specialty. Maybe a disadvantage for an MVP would be the reduction in the inventory in some cases. So there's a reduced inventory of measures to choose from for the quality and improvement activities area. And so in some cases, if you don't have that measure supported, or you don't do the improvement activity that's associated with the MVP, you aren't able to fulfill the full requirements of that. I hope that summarizes pretty well.
Yeah. Thank you. And I'll pose this one to the group as well. So if an oncology practice that has medical, radiation, gyn oncology under one tax ID selects MVP, can you clarify how that practice must submit as it relates to subgroups?
Valerie, I'll let you take that one.
Sure. So, of course, the first question based on next year and the proposal is if you're a small practice, you don't have to register as a subgroup. You can report all under the same tax ID as one group. If you're a large practice, then each of the individual subgroups, and you get to, again, under the proposal, attest to that, each of the individual subgroups would register, and you could choose to all report the same MVP, or you could choose to report different MVPs for the different subgroups. That's a real high-level explanation of how that would work.
Okay, great. Thank you, ladies, for answering that for Wade. We appreciate that. So, Michelle, I'll go ahead and turn it back over to you and talking about qualifying APM participants, if you would, please.
Sure. And this is one area that I find I get a lot of questions from my practices on. Sometimes you will find in final eligibility that some of your practitioners have been deemed what's called a QP, a qualifying participant. Oops, skipped ahead. 2 back, please. There we go. So with that, a QP is someone who has met a specific threshold by participating in an advanced APM during their various snapshot periods, which exist from January 1st through August 31st of the performance year. When you get that QP status, you are excluded from MIPS participation. You're also excluded from payment adjustments. And then starting in 2025 and beyond, there's no longer going to be that incentive payment associated with the QP status, but you are going to enjoy a higher physician fee schedule conversion factor, 0.75 instead of 0.25 for the non-QP status providers. So to become a QP, you have to, the full QP status at least, receive at least 75% of your Medicare Part B payments through that advanced APM during that performance period, or see at least 50% of Medicare patients through that entity. You can also get partial QP status, which leaves you still open to report MIPS and receiving MIPS payment adjustments. For that, you'd have to meet thresholds of at least 50% Part B payments or 35% of the patients, Medicare patients, through that advanced APM entity. Here are just a brief screenshot kind of outlining the different snapshots of QP determination periods. So the first one's January 1st through 31st of March. Second one covers January 1st all the way through June 30th. Third, all the way through August 30th. And then the final one is the full year. And they've just proposed some pretty modest updates to the APM and QP determination specifically. The current determination, they look at it at the APM entity and they use E&M services to determine which beneficiaries should be included. So they're proposing that they would be looking at both the individual clinician level now as well as the APM entity for determination of QP status, and then proposing more of a uniform calculation methodology for all covered services, not just the E&M values. And with that, I will go ahead and hand it back to you, Jackie.
All righty, well, thank you. Thank you all so much for that great information. We did have a couple of questions come in. In the past, I have heard from different sources that when you choose an MVP, you must perform well in all quality measures listed under that MVP. Today, I'm hearing that we get to choose 4 of the measures listed under an MVP. Could we get clarification of this, please?
Well, for the, I can take that one as well. You have a list of measures available to report on in both traditional and MVPs. The MVP list is usually just a little more consolidated. So if you are supporting more than 4, if you can track more than 4, then I think we all like to look at more than just 4 throughout the year so we can see what's the top, like which one of those are your top performing measures. And they will score you on the top 4. So you can submit more than 4 measures. They will just score you on your top 4 performing measures. Mm-hmm. So you have a choice. You're not limited to just picking 4, but you can report more than that, and they will score you on your top 4.
Okay, great. Thank you for that. And then also, Raymond asked, I have an unrelated question regarding the 7-point cap for topped-out measures. When calculating their contribution to the quality score, is their contribution 7 out of 10 or 7 out of 7? In other words, does the 7-point cap apply to both the numerator and denominator, or numerator only? And I'll throw that one out to Valerie.
Sure. So it is basically 7 out of 10. Reporting a 7-point cap measure does not reduce your denominator requirements. So it does somewhat limit your performance. So it would be 7 out of 10.
Okay, great. Thank you for that. And then also Madeline asked, when does the final rule take place? And that is something that, is to be announced after the proposal, and we'll talk about these dates here in just a moment, and that's a good segue into our final couple of slides here. So you see here the 12th of September, just to remind everyone, if you want to comment on the proposed rule, that comment period ends on the 12th of September. And you can see here the other dates following in October, as far as the last day to start the 90-day performance period for your improvement activities. We really anticipate that final rule will be available, I would say, by the beginning of December, if not the end of November. Typically, we see that time frame there. So certainly, feel free to reach out and use the links if you want to comment here on the proposed rule by the 12th of September, but we certainly want to make sure that you're aware there. And then additionally, if you have any further questions to submit and something maybe you thought about afterward, feel free to reach out to us. Our email address is qreg@intrinsic.com. And if you feel like maybe you could use some extra help and someone kind of taking a look at things and partnering with you to your success for MIPS, either for 2025 or 2026, feel free to reach out to our sales team here, either by phone at the 877 number or info@intrinsic.com. We work very closely with our sales team. They do a great job in making sure that you have all the questions answered, and if you feel like, well, I'd really like to learn a little bit more about your service, feel free to reach out to them, and we'd be happy to set up a call with you and a presentation to go over our offering. We know that there's a lot of options available for you. We consider ourselves to be a white glove service and partnering with you. We know that there's a lot of software solutions that provide great dashboards, but we are very hands-on and relational with our partnership with you and making sure that you feel that you have someone coming alongside and answering all those questions all throughout the entirety of the year, giving you those updates that you need. So if that's something that you feel that you could benefit from, again, feel free to reach out to us, but we will be sending out the recording as well as the handouts when they become available to the registration email that you used. And again, we'll be following up with a final rule webinar later this year when that final rule becomes available here as well. So again, we thank you so much for your time today. Thank you for all your great questions, and we hope to see you on the next webinar when we cover that final rule for 2026. So thanks again. Have a great rest of your summer, and we appreciate your time today. That will conclude our webinar for today. Thank you.